So I think we should probably get started. Hopefully everyone can hear us. Thank you for joining us, and I can see your names, but I'm not going to be looking continuously. So my name's Gideon Hirschfield. I'm a hepatologist in Toronto. Tonight is our first attempt at a joint effort to have a sort of series of case discussions around autoimmune liver disease, linking CASL with the Canadian Network for Autoimmune Liver Disease. Our goal, as we get this to evolve, is to go around Canada and to get different hosts in different cities to do a 1 hour interactive webinar on autoimmune liver disease, always being case focused. So tonight is our first effort. And so I hope you'll bear with us as we get good at our technology and we try and work out how to make this as interactive as possible, which is always difficult with Zoom calls. Dr. Flanagan is currently controlling the slides, so can you move to the next slide? We have had support for tonight from Gilead. It's been entirely independently prepared tonight. And we will be looking to make this a multi-sponsor educational series in the future. But we definitely are very grateful for Gilead for kickstarting this effort to raise education in autoimmune liver disease and improve the care for our patients living with PBC, PSC, autoimmune hepatitis, IgG4 disease, PFIC, Alagille's, rare liver diseases. Next slide. So I've introduced myself. I'm in Toronto. I'm going to be chairing and moderating, but we've got two excellent colleagues to do presentations of cases. I'm very grateful for them making the time. You all know Professor Montano-Loza, who's president-elect, in fact, of CASL, and is a hepatologist in Edmonton. And I'm delighted to introduce Dr. Eliza Flanagan, who's a senior autoimmune liver disease fellow in Toronto, who kindly stood up to offer to do a couple of cases for us tonight. Next slide. These are our relevant disclosures for myself and Aldo, and Dr. Flanagan has nothing to disclose. Next slide. So I'm going to hand over to Eliza. We have 3 cases. We'll try and do approximately 20 minutes for each one. It's very, very flexible. We'll see how we get on. And we're very happy to take questions. We'll try and see whether people put their hand up, but we'll have to sort of learn how to get that as efficiently as possible. So over to you, Dr. Flanagan.
Okay, so for case 1, we've got a 40-year-old female, so no past medical history. In January 2024, she presented to the emergency department with fatigue. She had a hemoglobin of 32. She was managed with an iron and blood transfusion and underwent both gastroscopy and colonoscopy, which demonstrated severe GAVE that was treated with APC. In May 2024, she had another episode of melena and had a repeat gastroscopy and again had GAVE that was treated with APC. When we look at the timeline here, so I'll just outline, I guess, orange is her hemoglobin. So this is her index presentation in January 2024. So very anemic. Blue is her platelet count. So she was mildly or moderately thrombocytopenic at that point. And in green here, we've got her ALP. So this was an index presentation in January 2024, and she hadn't really had any blood tests or liver enzymes checked before that. And in May, when she had her second episode of melena, she had repeat blood tests done, and her ALP was noted to be even higher, with a sort of ongoing anemia and a platelet count that had come up a little bit since her index presentation. So subsequent to this, she had some further investigations, and her liver function along with her blood count was monitored. In the context of her abnormal ALP, she had a serologic workup, including an ANA, which was positive. She had her immunoglobulins checked and her IgM was normal. She had a liver ultrasound that showed a normal biliary tree with no evidence of cirrhosis, but she was noted to have splenomegaly. And following on from this, in November 2024, she had her AMA checked, which was strongly positive. And in the context of her persistent thrombocytopenia at this point, she had a FibroScan, which demonstrated an elevated liver stiffness suggestive of cirrhosis. She subsequently had a CT in December 2024. Again, they commented on a normal liver, an enlarged spleen, patent vessels, and a normal biliary tree. So at this point, I guess the question in the community was, what was the diagnosis here and the stage of the disease? And what would be the next step? And does she need a biopsy?
So I could probably interject there, Eliza. I mean, and people are welcome to comment. I mean, I guess if I summarize what I see as a young patient, first off, who's got significant sort of bleeding complications. And to most of our eyes, I would say that the diagnosis should be reasonably straightforward, at least in terms of serology. And the stage, I would be predicting to be advanced. So I think you could tell that clinically. And I think that that would probably be the most important first step for this patient. So I guess the question is, why would you biopsy someone like this? I'll let you continue, perhaps, Eliza.
Yeah. So the decision at that point was for a biopsy. And so in January 2025, now 12 months after her initial presentation, she's undergone a liver biopsy, which has demonstrated focal portal granulomatous inflammation with the comment of diagnostic lesions of PBC not definitely seen, and a fibrosis stage on that biopsy specimen of 2 of 4. So at this point, she now has a diagnosis of GAVE and PBC, with a biopsy that's shown F2 fibrosis, but an elevated FibroScan and persistent thrombocytopenia with splenomegaly on imaging. And so at that point, January 2025, she started on urso. Her blood tests do improve with this, and we can see her ALP drops down to 193. Her other numbers remain relatively stable. However, then subsequent to this, she has another blood test while still on the ursodiol, and her ALP has come back up to 513. And at that point in the community, the thought was that the urso wasn't working. And so at that point, it was stopped. And so what happens next is that she has another bleed, so another episode of melena in July 2025. She has a blood test checked and her ALP is 400. Her other labs are pretty stable. And at that point, she undergoes a gastroscopy, which shows GAVE again, but now medium-sized esophageal varices and portal hypertensive gastropathy. And so subsequent to this, she actually developed new ascites. She underwent paracentesis and had some diuretics started. And that was followed by a CT scan in September, which showed splenomegaly, ascites, and finally some fine nodularity that they'd identified on the CT in keeping with cirrhosis. And so at that point, she was referred to our clinic. And when she came to see us, that was in September 2025. She had her bloods repeated, and unsurprisingly, she'd been off ursodiol. Her ALP is now 640. Other labs pretty stable. And she was put back on ursodiol. Her ALP improved over the next few months down to 330. And she was seen in clinic, recompensated at this point in January. This is sort of mid-January, early February 2026. So ascites had resolved, recompensated, and at that point she was started on seladelpar and carvedilol. Subsequent to this, her blood test improved and her ALP is now not normal but getting closer at 166. So that's the end of the case, and our discussion points from this case were really around the role of liver biopsy and when you would consider that and when it's needed. And so I guess this is just rehashing what we already know. So for a PBC diagnosis, the kind of chronic cholestasis along with the PBC-specific antibodies are enough to diagnose it, and you don't need a biopsy unless, of course, the diagnosis is not clear. You're considering a variant syndrome or steatotic liver disease as a confounder. But as was the case here, I guess a biopsy can be very confusing because it may not give you the answer. So this didn't show definite PBC, and it also showed F2 fibrosis when we could see clearly clinically that this lady was probably cirrhotic at her index bleed.
I'll just interject there. So maybe just to highlight, I mean, I guess, the downsides of biopsies, there's a delay. It has to add value, and in this case, it wasn't clear what the value of the biopsy was. And the worst case scenario is to biopsy someone where there's a very clear pathway for treatment, and we know about URSO and then second line treatments, and to be confused with the result because it doesn't quite fit, because the pathologist didn't call it PBC and they didn't call it cirrhosis, both of which were wrong, which may then delay the treatment for the patient, which is what counts. Biopsy is not a treatment, it's an investigation. And it may distract the provider and they may lose their sort of certainty as to the journey to follow. When in fact, this patient was a young woman who presented with cirrhosis and PBC, who really needed effective treatment to try and prevent more further progression. So I think in this case, that whilst liver biopsy is always interesting, I'm not sure it actually helped. Back to you, Eliza.
Yeah. And so then the other thing that I guess came up was what do you do with ursodiol treatment failure? And this was sort of in the community, and I guess they'd had the biopsy, which didn't definitely show PBC, and maybe that's what contributed to their decision making to stop the ursodiol. But we know that in PBC, regardless of response to urso with an ALP reduction, it should always be continued unless there are side effects or other reasons for stopping it. The other point is, so how do you decide when second line therapy is indicated? And this is a nice table stolen from an article that Gideon helped write. But just looking at how do you separate low risk from high risk PBC. And the table on the right just demonstrates high risk kind of features. And we know, so this is a young lady. She did have advanced fibrosis at diagnosis with elevated liver stiffness. She had an incomplete response to ursodiol, high baseline ALP, very high, and elevated liver stiffness. So, and unless they're very low risk, really we should be aiming for normalization of the ALP. And second line therapy, I guess, is now available in Canada, and that's why we should be aiming for normalization, because we do have these new medications, so the new PPAR therapy as well as obeticholic acid, and they're available if the ALP is above 1.67 times the upper limit of normal after 12 months of ursodiol, obviously, or if there's urso intolerance. OCA was contraindicated in this patient due to advanced portal hypertension, as a side note. So when we think about PBC therapies, obviously we've got urso, which is first line, and as mentioned, second line therapy with obeticholic acid, our next generation PPARs, and then off-label PPAR agonists, so bezafibrate, which we still have as well. Obviously, these need to be used in caution in patients with advanced PBC, and typically that's child PBC and decompensated patients. You need to be a bit more careful in this, and certainly it's contraindicated in decompensated patients, and obeticholic acid is contraindicated in anyone with portal hypertension. So that was the first case.
Yeah. So just before we go on, actually, we've got a few minutes on. We'll take advantage of that Aldo's here tonight, because this patient, apart from giving us really good insights into the value of first-line therapy and second-line therapy, and she's nearly normalized her ALP phos on addition of second-line therapy. She actually also highlights a topic that's perhaps a little bit more up-to-date, Aldo, about recompensation in liver disease, which has become quite a hot topic, really, hasn't it? So I didn't know if you wanted to, and it's certainly an Edmonton thing, if you wanted to give us some insights, because he has a patient who actually has very advanced PBC but recompensates fully, which is very different to some scenarios, isn't it?
Yes. No, totally. Really interesting case. And thank you, Eliza, for that great presentation. So definitely recompensation is something that can happen. It has been described mainly in other chronic conditions like alcohol or viral hepatitis, but there has been some studies in PBC. And basically are those patients who develop any sort of decompensation like ascites or variceal bleeding or hepatic encephalopathy, and then these complications resolve and they are under control. for at least 1 year, even that the new guidelines are, according to Babino, it seems like they are going to reduce the time to 6 months. So this is an example of a patient that actually with appropriate treatment, even that we are not curing the disease, we are controlling the disease, and the patient actually can recompensate. I think also the point that you mentioned about stopping URSO is important, even that the patient do not respond biochemically to ursodeoxycholic acid. We normally continue treatment, and then we add second-line treatments to the ursodeoxycholic acid, because there is a large study showing that patients without URSO or those who stop URSO, they have a worse liver transplant-free survival. And the emphasis that you mentioned, like definitely we need to be careful in patients who have decompensated cirrhosis, because we don't have a large body of evidence. I think definitely some patients has been treated in this condition, and definitely it seems like eventually we can be used them, but we need to be careful and always consider that if the decompensation is not resolving, this patient should be assessed for transplant.
Agree. And I think, I think when we tackled looking after this patient, we explained to the patient that, because of their age and their presentation, they had a very high risk phenotype, but we would do everything we could to put the brakes on her PBC. And because of her presentation being a portal hypertensive decompensation secondary to bleeding, if we could control the bleeding, and then put our brakes on the PBC with urso, and in this case we chose seladelpar, that gives her the best chance. She's still cirrhotic, it's still very advanced disease, but of delaying things and preventing transplant. And transplant in PBC is a challenge. They often have a low MELD score. They're disadvantaged on the wait list. It's not always a slam dunk that your patient with PBC will come to transplant. So I think there was a variety of learning points here. Don't be distracted by the biopsy. Don't stop the UDCA. Recompensation is a thing in PBC. Second line therapy can be used in this situation, and aim for normal, and that's essentially where we're at. I don't know if anyone wants to ask any questions. We're willing to try out if people could put their hand up or just unmic themselves before we move on to the next case.
And maybe just as a side note, recompensation happen in PBC approximately between 20 to 30% of cases, so it's not that frequent. And normally happen in patients, I guess, like her, where the MELD score tend to be low, because even though she has significant elevation of alkaline phosphatase and elevation of ALT and AST, it seems like the bilirubin was preserved. So patients who have a low MELD, they have a higher chance to recompensate compared to those patients who have a high MELD.
Exactly, and particularly portal hypertension. In fact, I'm seeing someone this week who's nearly 8 years post-TIPS, who recompensated post-TIPS, who then had no further bleeding, and bilirubin has stayed around 20 to 30, but has had a recompensated course for nearly 8 years with treatment. And with the portal hypertension management. Okay, I think Eliza, we should move on, and I think we're gonna do something very brave. We're gonna see whether Aldo can share his screen.
Sorry to interrupt.
Yeah.
There's a
All
question
right.
in the chat.
Oh, in the chat. Let me see if I can pull that up while Aldo's trying to. Is Elida? Well, the answer is I don't know that there's enough data to say whether one next generation PPAR is safer than the others. There's certainly some subtleties in the drug label. I think the best answer to that is proceed with caution when using any second line therapy, be that bezafibrate, seladelpar, or elafibranor. And there's certainly a lot of effort from the sponsors to get more data in cirrhosis. But generally speaking, we do want cirrhotic patients getting second line treatment.
Okay. So I hope everybody can see my screen. So I'm going to go over the second case. So this is a 60-year-old lady who was referred in 2016 because of abnormal liver function test. At that time, her weight was 87 and body mass index was 34. And these are the baseline liver function tests, where you can see that there was mild elevation of the bilirubin in 23. ALT and AST were elevated, 360 and 294, but the main pattern was cholestatic with an alkaline phosphatase of 670. So she did have serology for viral hepatitis that was negative. And then the important test that came back positive was a high IgG in 23, a high IgM in 5.6, and she was positive for antinuclear antibodies and highly positive for antimitochondrial antibodies, more than 900. So I guess the question for this case, with the information that I have presented, is, will you request a liver biopsy? Or will you go and start treatment right away with ursodeoxycholic acid plus prednisone? Or will you start ursodeoxycholic acid alone? And if nobody has any, I see some comments in the chat, but somebody is lifting.
That's a different. That's from the
okay.
the previous case.
So then I will continue. So I'm going to show what was decided at that point with this case, and it specifically was to proceed with the liver biopsy, given that there was elevation of liver enzymes more than 3 times the upper limit of normal, and there was also elevated an elevation of IgG. So this is the liver biopsy that actually was a good liver biopsy with adequate number of portal tracts. And as you can see, basically what we can see here is that in the portal area, there is a significant inflammatory component with lymphocytes and plasma cells and some eosinophils. But if you're able to see the first line of hepatocytes that are surrounding the portal area, the limiting plate, it's actually not that affected. So this was called as mild interface hepatitis. So basically there was significant biliary duct damage with portal inflammation, mixed population, and mild interface hepatitis. So because of that, we start treatment with ursodeoxycholic acid, 50 milligrams per kilogram of body weight. But based on the results of the liver biopsy, will you start prednisone too, or will you just continue with ursodeoxycholic acid alone? And
what do people think? Does anyone want to give prednisone, Dr. Flanagan? No, it's a no from Dr. Flanagan, so she's learnt well.
Okay.
I mean, it's an easy drug to give. Are there any downsides, Aldo, from giving prednisone?
Well, definitely there could be side effects, specifically in patients who have primary biliary cholangitis. We can increase the risk of bone disease. We can increase the risk of metabolic complications, especially because her BMI was high. But what I can see is that I guess our audience agree, because they mentioned to continue only with ursodeoxycholic acid. So let me show you what we did, and then we will go to discussion. So we continue with ursodeoxycholic acid, and then there was a decrease in alkaline phosphatase, that is the line in green, and then decrease in liver enzymes, that are the blue lines, and the yellow lines. But in 2018, patients start having pruritus, and because of that, and there was some evidence regarding the preliminary results of the FISH trial, so we decided to start bezafibrate 400 milligrams daily in combination with the ursodeoxycholic acid, and she has been treatment since then. And the last time that we saw the patient, the alkaline phosphatase is normal in around 120, and there is also normalization of ALT and AST. So she's doing well. So I think this case is a good example to show that in the case of primary biliary cholangitis, we know that this is a condition that affects mainly female patients, older patients, but also we need to recognize that a significant proportion of patients with PSC they have some histological evidence of interface hepatitis that normally is mild, and they can also have other features of autoimmune hepatitis. So that means approximately 30% of them will have positive antinuclear antibodies, and 20% of them, they will have high IgG. And the same happens in patients with autoimmune hepatitis. Approximately 20% of them will have some histological evidence of biliary damage. Approximately 23% will have antimitochondrial antibodies either at presentation or during their follow-up. And some of them will also have elevated IgM. So this case highlights that interface hepatitis can be observed in patients who have PBC and also PSC. And also that some patients with autoimmune hepatitis may have some features of bile injury. But what we need to do is we need to recognize which one is the dominant disease. So how do we make diagnosis of overlap syndrome? And these are really all criteria that were published by the group in Paris, the Oliver Chassuliers. But what I want to emphasize is that if we want to diagnose overlap syndrome, we need to have at least two of the three criteria for autoimmune hepatitis, so elevation of ALT, IgG. But it's mandatory to have a liver biopsy that show at least moderate to severe piecemeal necrosis or moderate to severe interface hepatitis. So that means that it's not infrequent to have mild interface hepatitis and PBC and even PSC, and that doesn't mean that the patient has a true overlap syndrome. So these are some of the histological features that we can see in these patients, specifically if they have like true overlap syndrome, even this term is a little bit arbitrary. And sometimes it's better to call them variants of PBC. They can have granulomas and they can have interface hepatitis with significant infiltration by plasma cells. And specifically, the classical moderate to severe interface hepatitis is what should make us consider that the patient has a true overlap syndrome. Something to consider is that this overlap syndrome has been described as sequential presentation. So that means a patient who has PBC and then develop autoimmune hepatitis, or concomitant. So that means the presence at baselines of two autoimmune liver conditions. Concomitant present is difficult to diagnose for the reasons I have mentioned. And I guess we still need to learn more about this overlap syndrome. This is an interesting study by Cynthia Levy that was published 12 years ago. And actually, she found that specifically in Florida, it seems like overlap syndrome was more frequent in Hispanic patients compared to non-Hispanic patients. And just briefly, when we talk about overlap syndrome, like what is important to try to talk about this condition is because, well, the treatment could be different, even that there is still not a complete consensus about that. There are some studies that actually have shown that including UDCA and corticosteroids with or without azathioprine has been shown to be of benefit. Other studies have been shown that ursodeoxycholic acid is useful when it's used by itself. And lastly, some studies using corticosteroids without azathioprine. But the series that we have are small, but definitely it seems like patients who have true overlap syndrome, they tend to have a higher risk of progression to cirrhosis that has been reported in the ballpark of 44 to 48 at 10 years, and up to 52 or 92 liver transplant-free survival at 10 years. So we don't have a lot of data, and I'm just going to show the results of this systematic review and meta-analysis that actually evaluate several small studies with patients with autoimmune hepatitis and PBC. And what they demonstrate is that actually the combination treatment using UDCA and corticosteroids actually did not have a benefit in symptom improvement. Also, this meta-analysis didn't show a significant improvement in biochemical response, and was not able to show also an improvement in the risk of progression of liver fibrosis. The only point that was positive is that the liver transplant-free survival was better in patients who were followed for more than 90 months and they received combination treatment with ursodeoxycholic acid plus corticosteroids and plus minus azathioprine. So it seems like specifically in those patients who we are confident about the diagnosis, then the combination treatment may be useful. Now that we are talking about decompensation cirrhosis and recompensation, I want to show this interesting study from China that they decide to evaluate patients who have decompensated cirrhosis secondary to overlap of PBC and autoimmune hepatitis. At the end, they evaluate 28 patients, and 14 of them were treated only with urso and 14 with urso and immunosuppression. And there was no difference in the frequency of decompensation. Having said that, the response to treatment was higher in patients in the combination treatment. And even that it was a really small study, they were able to show that actually the cumulative survival was better in these patients who have decompensated cirrhosis secondary to overlap PBC and autoimmune hepatitis, treated with combination of ursodeoxycholic acid and immunosuppression compared to those patients treated with ursodeoxycholic acid alone. So, to summarize, I guess this will be the current recommendation, and I will be really interested to know what are your thoughts. But for patients who have suspicious of primary biliary cholangitis and overlap with autoimmune hepatitis, if we really suspect that, we need to proceed with a liver biopsy, and that will mean mainly in patients who have a significant elevation of ALT and AST, at least 3 or 5 times the upper limit of normal. And if the patient has only mild interface hepatitis, it's okay to continue only with ursodeoxycholic acid in a daily basis. If the liver biopsy show moderate interface hepatitis, then it's also okay to start only with ursodeoxycholic acid and to evaluate response after 3 months. And if there is no improvement in ALT, then we could consider to add immunosuppression with prednisone and another antimetabolite that at this moment the evidence for autoimmune hepatitis is that we can use azathioprine or mycophenolate. And lastly, I think it's only going to be for those patients that they have significant elevation of liver enzymes and that the liver biopsy show severe interface hepatitis with severe piecemeal necrosis. Those patients are going to be the ones who may benefit to start combination treatment from the get-go, and then treat them similar as we treat PBC and autoimmune hepatitis. So that means ursodeoxycholic acid for life, and then immunosuppression treatment that has to be done for at least a couple of years, and consider withdraw immunosuppressions according to biochemical response. So for the discussion, I think definitely we tend to overdiagnose overlap syndrome. So we need to try to define well these cases, consider liver biopsy in the proper clinical scenario. And this is actually our experience in the CANAL registry. And this is actually showing how we tend to overdiagnose overlap syndrome. So in this table, sorry, it's really busy. I just want to show that we have over 5,000 patients who have diagnosis of autoimmune hepatitis and PBC. And of them, we have 198 patients categorized as overlap cases. Having said that, when we actually see how many of them meet Paris criteria, it was only 27%. So it seems like, again, we tend to overdiagnose this condition. And we do need to emphasize that if we think about this condition, liver biopsy is important, and the severity of interface hepatitis is important. And I think this is reflected according to the most recent guidelines, where they recommend to treat the primary or the dominant disorder, and most cases categorized as overlap syndrome. At the end, they have PBC with some hepatic component. And I think I'm going to stop here because we have time for questions, but also we are going to put a poll.
Well, let people just, it would be really helpful if you could fill out the poll to help us get information for future webinars. I'll just tease you a little bit, Aldo. You could probably convince me that sequential variant syndrome exists. You have a patient with PBC who then gets a new hepatitis, and there's no other trigger for it, and it seems to respond to steroids. I'm just interested to know what you think is going to happen to your variant presentation as we actually just basically treat the disease better and better and better, and as we introduce second generation therapies and next gen PPARs earlier. Do you still think we'll have this problem?
No, I agree. So to answer the first question, I think definitely the clinical scenario is different. Like if you have a patient who has a sequential presentation, it's easier to diagnose because basically you know that the patient has been treated properly and then they develop a second autoimmune liver disease. In the case of concomitant presentation, I think maybe we will be seeing less cases because if the patient has PBC and the patient has incomplete response to ursodeoxycholic acid, adding a second-line treatment is going to increase the chances of biochemical response. And some of the inflammation actually is going to improve with the second-line treatment. And that has been evident, like, for example, with obeticholic acid and also with the new fibrates.
Yeah, I mean, I think if you were to look at the practice in Paris, where they used to recommend budesonide if you had UDCA insufficiency with a high ALT, in essence, after a liver biopsy, I think they're hardly using any budesonide, and instead they're using UDCA plus PPARs.
Yes.
So, I mean, I'm not saying that PBC is not inflammatory. It is. I'm not saying patients with PBC don't get interface hepatitis. They do. I'm just always a little bit nervous to overdiagnose something that's rare, commit a patient to drugs that will probably give them osteoporosis, and certainly, as we're going to show in the next case, delay effective second-line therapy. So I think it's really hard, and maybe one of the things we'll do in a future webinar is try and get a pathologist to join us and actually do a sort of webinar on histopathology and autoimmune liver disease. And then you'll start to see how hard it is for your pathologist to really call what's going on. And it can be very difficult to see the biliary lesions, and what you're left with is the pathologist, I don't want to use the word over-reporting, but focusing on the interface, because they're much more tuned into picking up interface than they are to picking up biliary lesions. I'm just seeing if there's any questions.
And in the meantime, I totally agree with you. Actually, you have a really nice paper in Journal of Hepatology in 2021 where you use budesonide for patients who have PBC and looking for inflammatory activity in the liver biopsy. And it was interesting that the primary endpoint was not met, like histological improvement, but biochemical response was met. So that means that this budesonide may be useful also to reduce inflammation, but at the same time, with new second-line treatments, I think we can treat this inflammation component with less side effects, right? Because steroids definitely come with significant side effects burden in PBC.
For sure. And I think that's very important. Just to answer the question in the chat, everyone does it slightly differently, but I would encourage you to delay biopsying your patient until you've actually given them a good treatment trial with UDCA. because you'll bias yourself because you're not biopsying most people with PBC, and most people with PBC have got interface hepatitis. So I think generally speaking, these patients can be treated. They're not so sick like an acute AIH where it's obvious. They're not jaundiced. And so the only patient where I might really consider it would be if they were presenting more like AIH and they were jaundiced and they had a high IgG, which is actually quite unusual for PBC. So I would recommend that you follow what Isel said, treat the dominant disease, take a deep breath, wait and see, okay, and see where you land at 3 to 6 months. And usually what you'll see is your primary PBC therapies are the ones that are getting control. And if you biopsy infrequently, then actually all you're going to do is get cognitive bias because you chose to biopsy them for a reason. So you'll overinflate the interpretation of your interface. But with that, I think we should move on to the last case. We've done the poll. I hope everyone had a chance to fill in the poll. We'll go back to Dr. Flanagan, who actually has a nice case to illustrate. I don't want to use the word prove, Dr. Flanagan, but maybe it does prove, to illustrate that point. Thank you, Dr. Flanagan.
So our third case is a 45-year-old gentleman. So he had a past medical history of Graves' disease and bowel cancer in 2020 that had a sort of complete resection. He didn't require any adjuvant therapy for that. So when his bowel cancer was diagnosed, he had a blood test done, and this time we've got AST in orange, ALT in blue, and ALP in green. So we can see here all of his numbers were a little bit elevated, but this is predominantly cholestasis. He underwent imaging at that time, so he had an ultrasound and an MRI, which showed normal liver and normal biliary tree. Subsequent to this, he didn't get repeat blood tests done for sort of about 12 months. And at that point, his blood tests were repeated in early 2021, and his ALP was a bit higher, 495. And both his ALT and AST had also risen at that point. So he had a serologic workup done. He was noted to have an ANA, which was a strongly positive, speckled and mitochondrial pattern. He had an elevated IgG and an elevated IgM, which was very high at 13. He was AMA and SMA negative. And so at this point, he was started on ursodiol, and his blood tests improved. So again, his ALP has gone down a little bit to 209. But then he's had another blood test done in July, so 4 months sort of after the urso initiation, and his ALP is 461, and his ALT is now 424. And so at this point, the question of, well, what do you do now? So he's strongly ANA positive, his IgG is high. It looks like they'd presumed that his diagnosis was PBC and started him on ursodiol, but it looks like people are starting to get a little bit nervous because his ALT has suddenly popped up. And so at this point, do you biopsy? Do you wait? What do you do here? So I don't know if you want to comment, Gideon, or we'll just keep going.
No, I think we can keep going because I mean I'll admit it'd be a brave person not to biopsy a PBC patient with an ALT of 424. I am brave, but I'm not suggesting other people should be brave. So I think it's okay to biopsy this patient.
So he had a liver biopsy. This was August 2021 now. And the biopsy is shown, described as showing a chronic hepatitis with both cholestatic and sort of hepatitis components. They've commented there's a cholestatic pattern with some bile duct injury, and with this high IgM and elevated ALP, then they would favour AMA negative PBC. But then they've also commented he's got moderate to severe interface activity with some moderate necroinflammation and early bridging necrosis. And they've looked at his high IgG and positive ANA and said, okay, he's also probably got autoimmune hepatitis.
And just to add, I think that's a pathological error. The last sentence is including information that you didn't actually ask of the pathologist. And they're linking what they can see to other issues and then not linking inflammation necessarily to PBC. So they may be right, they may be wrong, but actually that's an oversynthesis, I'd argue. Sorry, Eliza.
That's okay. And so with that biopsy now in mind, he is started on budesonide. So it's August 2021. started on budesonide, and his blood tests do improve. So his ALP comes down, his ALT and AST both also come down. At that point, it's now March 2022. He's referred for a second opinion about whether or not this is true overlap. At that stage, he's got mild pruritus. He has a FibroScan in clinic, and he's got a normal liver stiffness. His serology is repeated, and now his AMA is strongly positive with a positive GP210. His SMA and LKM are both negative, and his ANA remains positive. And so at that point, budesonide was ceased, and he was started on second-line therapy with OCA at 10 milligrams per day. And with that, his blood tests continued to improve. His ALP continued to come down, as did his ALT and AST, despite having ceased the budesonide. And so at this point now, he's been on the OCA since March 2022. We're now in 2023, and his ALP is still a little bit elevated, 170, but otherwise his blood tests are looking pretty good, and his ALT and AST are both normal. So he comes back to clinic for review, and at that point, he is started on bezafibrate as triple therapy for his PBC, and his blood tests improve and actually normalize. So all of his liver enzymes are now within normal range, although his ALT and AST are a tiny bit elevated. And so his repeat liver stiffness looks pretty good, 5.7, relatively similar to his index FibroScan. So in this patient, he's a high-risk patient, he's male, he's young, he's had incomplete URSO response initially. His index ALP was above 3 times upper limit of normal, and his GP210 positive. And so even though he's got a normal FibroScan at index review, he's a very high-risk patient, and he has normalized his ALP now on triple therapy with the budesonide ceased. So discussion points for this case were really, was this true variant, or is this just inflammatory PBC? And I suppose it's easier in retrospect to look at that and say, okay, we stopped his immunosuppression and his numbers still got better. So it does look like pure PBC from that perspective. His auto antibody profile, I guess, was suggestive of possible AIH, but really more in keeping with PBC, as was his cholestasis. When the ALP is very high, as Aldo was saying, you can have hepatocyte inflammation, and you often get this interface hepatitis. The biopsy obviously made things more confusing rather than probably helping with this scenario. But with this case, all of his enzymes really improved quite significantly within 6 months of starting URSO, and they've normalized his ALP on triple therapy. So his spike in ALT was interesting. I mean, this was before we met him, and it's unclear if he had a PBC flare or maybe he was non-compliant with his medications. Certainly, it was very reasonable to biopsy him at that time. And as Aldo mentioned, budesonide in PBC, it does improve biochemical markers, and that's probably what we were seeing with that initial response. And the last point was just that in this young patient, complete disease control was achieved by controlling his PBC. So I think that is all that we had, and we'll just open to questions.
That's great. Well, thank you, Dr. Flanagan. I thought that's a really interesting case, because he came to us, as a variant syndrome on budesonide, but as a non-responder. So he met criteria for second-line treatment. We took a step back and said, it's more likely, given his phenotype, that he needs better PBC treatment, and that the budesonide is not actually contributing to his outcome. So we optimized his second-line treatment, which was OCA first, and then a PPAR agonist. And we were able to remove his immunosuppression completely. And remember, budesonide long-term will give you cortisol suppression, will affect your bones. And we've controlled his whole clinical phenotype with PBC therapy. So I think the message isn't that PBC is an immune-mediated disease. You can have immune features, but generally those immune features are driven by the PBC. And if we can control the PBC better, and we can now control PBC much better than we ever used to be able to with our second-line therapies, actually that's a better way to manage the disease than it is to give a non-specific therapy like corticosteroids and just dampen down generally the interface hepatitis. And you would expect to see some impact of immunosuppression, and we do see that. There were original trials from Jenny Hethker of azathioprine in autoimmune hepatitis, and we have seen patients who were on azathioprine because they supposedly had AIH, who, when you stop the azathioprine, you see a bit of a flare. But then when you come in and treat their PBC with second-line treatment, the PBC is controlled and the ALT comes back down to normal. So I think not everything that gives a high ALT is autoimmune hepatitis. Would be a message. I don't know what you think, Aldo, how that fits into your kind of framework that you gave everybody with your variant syndrome.
Yeah, no, I think this is a really nice case that illustrates that PBC definitely is frequently associated with other autoimmune factors, but definitely they tend to have a high ALT. It's frequent for patients with PBC to have antinuclear antibodies. I think specifically if you have other serology, like maybe anti-smooth muscle antibodies that also can be seen in PBC, or anti-soluble liver antigen, a sialoglycoprotein, maybe that can tell you, okay, maybe I'm seeing a patient with autoimmune hepatitis, but antinuclear antibodies are so frequent in PBC that definitely that should not mislead the diagnosis. And I agree. I still think that we will be seeing a small percentage of patients that actually have a true overlap or really variants of PBC with AIH, but it's going to be a minority. And given the safety and the side effects profile, it's better to be aggressive in the treatment of PBC instead of deciding to commit the patient to long-term immunosuppressions and the side effects that implies. I think definitely this case have all the features for high risk of poor response. Male, young, he had positive anti-GP 210, and have alkaline phosphatase. I think the only comment I was going to see, to me, it was interesting during the presentation that he was on UDCA and he had improvement in the alkaline phosphatase, and then he totally lose the response, and the alkaline phosphatase were over 300. So I wonder, at that time, I will ask about if he stopped the urso, if he was taking the right dose, what happened there. But we have seen this, right? Sometimes patients just lose response.
Yeah, I agree. And I'm not saying don't look at the ALT. We've got a paper from Global PBC that we will submit very soon. It's slightly overdue to be submitted, but demonstrating that elevated ALT is prognostic in those groups of patients who are, non-responders by alkaline phosphatase. And, therefore you should be looking at your second line therapies to also help FOS and to improve ALT. I guess, in future webinars, we'll try and cover PSC variant syndromes because they're also very confusing and they are slightly different. What I will say is they have in common that the younger the patient, the more the response immunologically can be hepatitic. And so I think you see that in both PBC and in PSC. I think in PSC, it's just slightly harder to know because sometimes you have a patient who's a bit more responsive to the AIH variant. But I think my message there is that doesn't have to commit them to treatment for life with immunosuppression that may have side effects. So it may be a phase of their immune-mediated liver disease that has higher steroid responsiveness, but that does not necessarily equal true autoimmune hepatitis. And true autoimmune hepatitis has a paradigm of care, and that's a very important paradigm of care. The variant syndromes, the mistake that people make is they keep going with treatments when they've stopped helping the patient and maybe harming the patient from long-term corticosteroids or long-term immunosuppression. Do we have any questions and answers as we wrap up to the last couple of minutes? Do you want to just move to the last slide for me, Eliza? there doesn't seem to be any questions, and we realize this platform, we are going to give some thought to how to make it as interactive as possible. We thank everyone for coming. We hope our opener was enjoyable. We are about to secure a date in September for the next webinar, which will have a similar format, including cases. We've already have a volunteer fellow who has volunteered to present for us. So we'll announce the date quite soon and make sure everyone's got a link to it. With that, I'll thank Professor Montano-Loza, I'll thank Dr. Flanagan, and I'll thank CASL for helping us organize this, and Gilead for providing us the support to allow us to do this evening. And feel free to reply to some of the links in the chat. And have a good evening, everybody. Thank you.
Have a good evening. Thank you all.
Bye-bye.